Hello, and welcome to another episode of Improve Healthcare, the show that focuses on ideas and insights to improve the healthcare delivery continuum around policies, processes, and patients. I'm your host, Rich Greenhill. In this episode, we'll focus on shortages in the healthcare rural workforce, as well as opioid use disorder and how those are linked. Our special guest today is Dr. Carrie S. Dr. Shaver is a clinical assistant professor in the Division of Health Sciences and the director of the Community Health Advocacy Program and Regional Healthcare Pipeline at the Indiana University campus in Columbus. Her research focuses on rural public health, in particular prevention, treatment, and wellness for patients with opioid use disorder. Prior to her career in academia, she administered prevention, treatment, and health and wellness programs for at-risk populations. So, Dr. Shaver, how are you today?
I'm well. Thank you, Rich, for having me. It's such a pleasure to be here.
Yeah, it's good to have you and good to speak with you again. So first, we'll start out. Tell us a little bit about your background and what you did before, and just kind of set the conversation up a little bit.
Sure. So I started in the social service sector, working healthcare administration for programs targeting at-risk folks. So I worked first with prevention, wellness, and treatment for HIV/AIDS in Flint, Michigan, where I'm from. And then I worked administering programs for youth and adolescents, ranging from kindergartners with hygiene and illness prevention all the way up to young women and STI pregnancy prevention.
Wow, that's amazing work. So, and now with your research, you're working on opioid use disorder, obviously, and the rural workforce. So how did you transition from that social services type work into what you're doing now?
Sure. So growing up, my childhood was split between Flint, Michigan, which is a Black urban center, and the west coast of Michigan in very rural counties. My school was Class D pig farming community. So I have this affinity for both the urban center and rural areas. And what I found as I transitioned from an urban center into higher education is that there's a lot in common in terms of health access and wellness between those two groups. You'll find that they share a lot of the same challenges, but in different ways.
Well, that's really wonderful and great work, for folks who need us most. So today's topic is really timely as the nation and the world really grapples with an exhausted workforce from the COVID-19 pandemic. And from your time working in the HIV realm, it was the same type of thing at that time. It was something, a disease that people didn't understand. I was probably a child at that time, but same types of things that we're seeing, and some of those same trends that are playing out. The Rural Health Resource Center noted that there are a host of factors that impact healthcare provider supply. Things like retirement, aging, and insurance, to just name a few. So any trends you're seeing there in Indiana as related to workforce shortages?
Sure. So it is remarkably similar to the rest of the nation in terms of rural healthcare workforce. And you mentioned HIV. The same issues are at play with opioid use disorder, OUD. That stigma first and foremost, and then limited access to providers. So these issues impacting the rural healthcare workforce, and of course, rural areas are the ones most impacted by opioid use disorder. This has been primarily a rural issue, even though it's making inroads into urban centers. We just have we have too few folks who are interested and willing to work in rural areas. Some of that is due to this dispersed, dwindling, aging, and diversifying population. So providers, unless they're incentivized or are from rural areas themselves, don't find working in rural Indiana or rural America very attractive. Mm-hmm. The amenities that you can receive in an urban center or the suburban areas outside are simply not present in a lot of rural areas. In addition, we have a rural skepticism of higher education that can be found. So in our work recruiting high school students for health professions, there is a serious distrust of borrowing money in order to have a higher education. As you know, education costs have continued to increase, and many folks they don't have a choice, they have to receive federal loans or outside business loans in order to support themselves or their children in attaining a higher education. And there's a skepticism about the value of that loan. So we have those issues as well in terms of that healthcare workforce.
That's really interesting, Carrie. You and I did some work together in a recent publication, and some of what we talked about were rural hospital closures and how those have peaked. And when you think about on top of what you mentioned, there's the desire for pay and prestige. I mean, when you get out of medical school, or if you're thinking about becoming a nurse, you want to work for the best, right? So if you have to drive miles to get to a hospital and you don't want to leave your community, if you're from that community, it may be hard to keep you. Also, great points about the educational system. It's educational costs. I mean, we've seen a lot of that recently with the COVID pandemic. That back when you and I came along, when you left college, you could get a job, or you knew there'd be something. Now, we live in a different world, and you could get a 4-year degree, or become a nurse, and maybe there's not a job for you, or maybe the job doesn't pay what you thought it was going to pay. I mean, all a host of issues. And so, interestingly, how do you think opioid use disorder and these rural workforce shortages are related?
Sure. So right now, access to treatment is just really difficult in rural areas. And I'll speak to Southern Indiana in particular, where I'm located. We simply don't have enough providers, period. We're in a primary care provider shortage. We're also in a mental health counseling shortage. We don't have enough of those clinicians as well. And the providers that we do have, not enough are X-waivered to provide medications for opioid use disorder. In addition, residential treatment centers are few and far between. There are wait lists for beds. The state of Indiana is doing an excellent job on ramping up those particular facilities through grant applications with SAMHSA and other federal units. But that work is still in progress. And in the interim, especially during COVID-19, we are seeing the results of not having that access. So while we were in decline previous to COVID-19, a good spot to be in with this pandemic and the extremely limited access to providers, we've seen an enormous increase in overdose deaths and overdose.
Yeah, there was a statistic that I saw you wrote about that in one of the counties there, that you're more likely to die of an opioid disorder than a car accident. Like, that's just amazing to me.
Yes, it has become endemic in particular communities. So, for example, in Southern Indiana, where I'm at, of the 9 communities that the CDC identified as having very high risk of intravenous drug transmission of disease, 7 are in my region. So of the 9 in Indiana, wow, of the 200 the CDC identified, 7 are where, Indiana University in Columbus is at. 7 of those counties, you're very likely, if you use intravenous drugs, to also become infected with hepatitis or HIV. And as you know, the Scott County epidemic was just a few counties away from us here in Columbus.
Yeah, I think I saw a documentary on that. It was just really amazing to watch. I mean, just ravaged the community. And, I'd like to also ask you about your opioid use disorder research that I'm aware of. I mean, you've done some really great things. You want to talk to us about your interest in opioid use? How did you get interested in that type of research? And what are some of the things that you've seen in some of your research?
So I really think the first interest was just how devastating this epidemic is on rural communities. And if you're in a rural community, as I am, you see the impact. So that public health impact is what drew me in, and its similarity to HIV, for example, was stigma, lack of access, communities turning away from those with the disease, not understanding opioid use disorder as a disease and not a personal failing. All of those things felt very similar to me. In addition, the death rate from overdose, we are losing entire swaths of young adults in these communities. And it's just heartbreaking. And it reminded me very much of my work with HIV. And like HIV, we are developing the tools to manage this public health epidemic. These deaths are avoidable if we allocate the resources, including workforce, that's needed in these areas. We can make an impact and change.
Yeah, we hope with some of the laws that are being passed now that the public health infrastructure, including the workforce, is strengthened in the nation. And, it resonates that, having known people who have, gone from having chronic pain to becoming addicted, it can happen very quickly. And,
Right.
I can remember back in the day, I had a couple surgeries, not very many in life, but what do they hand you? They hand you a bottle of Tramadol or Percocet, right?
Right.
And so, and still to this day, I mean, I think that, the clinicians think they're helping you, and they are, but, they also have to be vigilant to the fact that some of these drugs are highly addictive. And after a couple doses, you may literally be hooked,
Sure. So some of the research that I have done is around best practice domains, and of course, prescribing guidelines are part of those best practice domains. So I looked at state response, including Indiana, to assess like how are our health policies, how are they in relationship with evidence-based practice, right? How are we doing? And then on a more local level, looking at the region, again, those 7 counties were part of this that were identified by the CDC as at risk for, intravenous drug use, infection of bloodborne pathogens. So, being able to look at the best practice domains, evidence-based practice, assess where your state is, and then where your health systems are in terms of application, really gives us some concrete ways to move forward in the administration of opioid use disorder epidemic response.
Yeah, I know that was some great research that we partnered on there. Around your comparative analysis, and I'm wondering, did you see a link or any type of associations between whether those states, expanded Medicaid or not, and of the exemplar programs? What types of programs did you see in those states that are doing better than others in the exemplar states?
So in the exemplar stage, you'll see that they address stigma head on, right? So they've adopted evidence-based practice. And one of the things that's controversial in rural areas are things like syringe service programs.
Mm-hmm.
There's a sense in the community and among some clinicians that by providing safe needles for heroin injection, by providing those supplies, you're encouraging drug use. Now, that's not what the data bears out, right? The data shows that if you have a syringe service program, folks are more likely to get into recovery. They're more likely to obtain Medicaid, right? There are all these wraparound services that are associated with mobile units. And in rural areas, you need a mobile unit, you need a nurse, you need a social worker providing those services and going to people where they are, because transportation is such an issue in such a geographically dispersed area. So an exemplar state is taking a look at evidence-based practice and then doing the communication required to remove stigma around programs and activities that really help folks versus our feelings and ideas about morality and opioid use disorder.
Yeah, there's a couple things that there's great overlap between opioid use disorder and HIV. In my experience, the Black church, for example, doesn't want to talk about HIV, but it's something that you need to talk about in order to make a difference, right? Because if you don't acknowledge it's a problem, you can't work on it. So that's right. Interesting overlap between those two. The other thing is you talk about needle exchange or drop off boxes. I remember when I was in the Navy, we went to Australia, and I remember being out with some friends and seeing in clubs in different places that they had the needle boxes in the late 90s. I mean, so they recognized again that they had, and I don't know if there's been any current updates to that, but back then they recognized that they had an issue, right? And they were just very open about the fact that if you had your needle, bring it there and drop it. And like you said, if it does help people, then that's what counts, right? I mean, and along those lines, Carrie, because what we're talking about here is culture, right? And culture, there's a saying, you probably have heard it: culture eats strategy, or for lunch, or you hear people spin it different ways, and it does, right? You can have all the great plans in the world for anything, but if you don't have the culture on board with what you're trying to do, it's not going to go anywhere. So, how do you think we overcome in the rural health space some of the cultural views, challenges of dealing with opioid use, and to make some real progress? Because we can have our feelings about things, but there's also the reality, right? And how would you react to that?
Well, I would just say that you have to have interpersonal relationships in rural communities. You can't step in from the outside and try to tell people what to do. In rural communities, those relationships are built over decades and built on trust and reciprocity. So you absolutely have to find an advocate in a community, gain the trust of the advocate, and work through and with the advocate in order to bring more folks on board. And you'll find in rural communities, the greatest strengths of rural communities around opioid use disorder are usually family members who are impacted or those with opioid use disorder themselves. Because a large part, and this is starting to change now, but a large part of the issue is the silence around this disease. And being able to conceptualize it as a community, as a disease versus a personal moral failing is where you have to start. And a lot of the communities here are doing that work now.
Yeah, I recall when I was an executive in the safety net, we had something called cultural champions, and they were these things called community health workers. I'm sure you might have heard of them.
Sure, yeah.
And so, they're embedded in the community, they're part of the community, and they were instrumental in helping us focus, because at the time in Austin, we were trying to, reduce the rates of pregnancy and those kinds of things, right? And so, we had, without naming the culture, we were working with a culture that, had certain beliefs about, contraception. And so we had to really work through the community health workers to get them to assist us with talking to people. Because if I walked in there, I'm a male, this group is not going to listen to me about,
right.
Let me tell you about birth control. They're going to be like, who are you? You're not qualified. You don't understand our culture, right? So that's
right.
Very well stated there.
Yeah, I'm really proud of the work, for example, that Madison County is doing in the, tippy southern part of the state. One of the hospital there, King's Daughters Health, and the health department and other stakeholders have specifically identified adverse childhood experiences as a cause of poor public health in their area. So they're struggling with opioid use disorder, extraordinary suicide rates, and poverty, and low educational attainment. So the community has come together around these adverse childhood experiences, and one of those is having a parent with opioid use disorder, right, a chronic illness, which is also often accompanied by time spent in jail. So they're working on all these adverse childhood experiences by helping adults in the region. So there's some really proactive and innovative work that's being done in our communities here to address these issues.
That's great. And I know that you're speaking a lot and doing some presentations, and you have some abstracts into some conferences to share this knowledge, because it's very important that, I mean, you really are doing great work. I wonder, with your thoughts on the rural workforce shortages,
Sure.
what do you all have any programs that you're working on, or do you know of any that are um, to help people plan for their workforce, right? We know there's an issue. So you mentioned recruitment earlier as a challenge and keeping people there. What do you think folks can do to prep or plan for their rural workforce, right? In
Sure.
the community?
So yeah, we have a very good convening group through the Community Education Coalition here in Columbus. And members of this healthcare guiding team include representatives from higher education. So I serve on that committee representing Indiana University at Columbus. And then we have our Ivy Tech Community College representative for health allied programming and for nursing. In addition, we have employers and other stakeholders in that group. The group has convened for about 5 years now. And one of the first things that we did was stakeholder engagement activities to build trust and to get to know one another. And from that work, we identified goals and objectives, and we've been working on them, and we've had some really great successes. So, for example, at Indiana University, we have doubled our pre-licensure nursing track, the size of that, because of the nursing workforce shortage.
Wow.
We added an accelerated second degree BSN program, and that was from those talks that we had with employers. We added a Master's of Science in Nursing Family Nurse Practitioner program.
Okay.
We have a brand new baccalaureate degree called Community Health Advocacy. So when you talked about community health workers earlier, I'm very familiar with this. It's a very similar type of position, but it's a baccalaureate degree. So you'd be looking at folks who are supervising community health workers, organizing, strategizing, providing that leadership in engaging the community on public health issues. So we have those folks as well. And that came out of this group deciding to collect data together and going to representatives of 98% of the healthcare employers in our community and figuring out what those critical and hard to fill positions were, and then creating programs around that. So nursing was top of the list, and primary care providers come next. What we could do with that is what we did with the MSN FNP program by developing and starting it. Our first graduates are this May, so we're very excited.
That's amazing.
Commencement ceremony with our brand new MSN FNPs. And, it's just, and then the other work we're doing is around having folks do their undergraduate here in biology or community health advocacy or psych, and supporting their application to med school or to become an occupational therapist, any of these professional graduate programs. We want to maintain those connections with students, with residents, so that we can bring those folks back. And the Area Health Education Center, which is a national organization, our local folks help us with that placement of students from our region who go on to those professional graduate programs, getting their residencies here. They're more likely to stay here if we stay in contact with them. And then, of course, they have their family pressure to be around. We're working really hard to retain our local natural talent, at the same time trying to become attractive to outside folks.
I love that.
Both of the initiatives are simultaneous.
I love that. Local natural talent. You should brand that. Well, it sounds like, I mean, that is phenomenal that you're formalizing this community health worker into a degree. That's really amazing, because I think that what I saw here years ago is, there was often the training wasn't all the same. And I think Texas is doing a great job with some of its community health worker training, but, making it into a degree is just the next level. And it sounds like, Carrie, that your university and you're part of this leadership is building a community,
That's right.
a community, and and an infrastructure there that's going to make you successful. As someone who grew up in a rural area for part of my life, I think that this is important. Community. It was all about community and
That's
family.
right.
And so you're building the legs of family there
That's right.
around your workforce. So amazing. So I want to thank you, Carrie. Your work is very inspiring, and I look so much forward to seeing more of your work. And of course, I follow you, and you're a colleague and a good friend. So it's just been a pleasure to have you. I've learned some things today from you that I didn't know around the work that you're doing, and I'm sure our listeners will feel like this was valued. So really appreciate you taking time today.
Thank you very much, Reg. It was my pleasure to be here.
Thank you. I'll talk to you soon.
Bye-bye.